Hello, everybody. I'm Siri Vaith, Executive Director of Cystic Fibrosis Research Incorporated, CFRI, and I am happy to welcome all of you to session number 4, a question and answer period with Dr. Rick Moss. And for those of you who have not been a part of these past recordings that we've had and don't know Dr. Moss, he is a preeminent cystic fibrosis clinician, pulmonologist, researcher, professor emeritus at Stanford, and was the director of the Stanford CF Center for many, many years. And I say quite proudly, he is also a member of CFRI's board of directors. So I thank everybody who sent in questions during the week. That we will jump into in just one moment. But again, as always, I must say that the following information should not be used for medical advice, diagnosis, or treatment. And please consult with your physician before making any changes to your medical care plan. I also want to make sure you all know it is April 15th as we are recording this. And the reason that date is so important is that the information just changes almost hourly sometimes. And so if you're watching a recording of this later, the information contained therein may have changed since then. So with that, I am going to launch the questions to Dr. Moss. Hello, Dr. Moss.
Hi, Siri. Good to see you again.
So as always, we start each week asking you for the current number of reported cases and deaths.
Yes, so we're over the 2 million mark worldwide now in terms of identified cases, and that includes over 130,000 deaths. Here in the United States, the figure is closing in on 625,000 cases and 27,500 deaths. Recently, the news media have emphasized that this is not a complete count. There are many people that are dying before encountering the healthcare system and getting tested, and those deaths don't go into that count. And there are others that are maybe dying of other reasons that are related that are also not included in the count. So one should probably add about 10 to 15% to those figures, at least in the developed world. It may be far higher in certain other areas of the world where reporting is not as good also.
Stunning. So related to that, where are we with reliable testing and all the news we're getting about a high percentage of false negatives? I'll start with that question.
Yeah, the question of the accuracy of the test is a very important one. And I think in general, the technology that's used, which is something called PCR, it's a way to find genetic material, is very accurate, but its sensitivity is often limited not so much by what happens in the lab as to how the sample is collected. So there may be cases that are being false negative because of poor sample collection, and that is a concern. False negative rates are generally fairly low, but can be up to 10 or 15% in some cases. There's not just one test that's out there. There are now a number of different tests which have been offered not just through public sources, but also through companies. So it's a bit of a muddled situation. And of course, that's still not the biggest issue, which is the distribution of the tests, producing them in sufficient volume, having enough reagents or materials that you need to do the tests, like viral transfer media, which is what you take that swab and put it in before it goes to the lab. These are all parts of the test. So for all those reasons, there are many places where people cannot get tested. In many locales, you need a doctor's order to have a test. You can't just go up to a place and say, can I have the test? And in many situations, those tests are still restricted to people that have symptoms suggested that they're coming down with the illness. And if you're healthy, they will turn you away without admitting you to get a test. So we're very far short of where we need to be. Where we need to be is tests that are very widely used so we get a real idea of how many people out in the population are actually infected. There are enough studies now that indicate that probably between a quarter and half of those people who actually have it are not symptomatic enough to seek testing. So that's a real problem. And that's a huge reason for this whole issue of physical distancing, because of the asymptomatic or pre-symptomatic
carriers who can still spread the disease. And the new tests that are just coming out where they use saliva instead of doing the nasal swab, are those considered to be as effective in terms of accuracy? Unfortunately, things are moving so quickly that people are starting to use a lot of these tests without thoroughly validating their performance. And that would, I think, apply to some tests that use other body fluids as a source to test for. And I think that is one of the things that has to be worked out over time. So it's not an ideal world, but in general, testing has improved. There's no question about it. But we're still way behind the 8 ball in terms of where we need to be. We have 2 questions that are somewhat related, so I'll just lump them together. We did get a question from someone who lives in the United Kingdom who has a 7-year-old daughter, double Delta 508, and they're sheltering in place, who is very curious to know if there are any updated statistics about CF cases in the United States or elsewhere, and how many people have recovered. A related question with that tracking of people with CF is whether the CF Foundation here in the States is tracking specifically individuals with CF who develop COVID-19. So there's no systematic way to collect that information, because remember, all the information that you see on all these websites that track are relying on things like public health department statistics that are put out and collating them. To my knowledge, the CF Foundation is not doing that in the United States, and other CF national foundations are not doing that. What we do see are things that get onto social media primarily, or in the general media. And at this point, all I know about it are a couple of cases in the United States, one a child, one an adult, 2 adults actually, and 5 cases in the United Kingdom, 1 in Ireland, and about 10 cases in Germany. And these things are all kind of just trickling out there. That's very, very anecdotal experience. So far, though, I've not heard of any fatalities in CF, and that's great. But we don't know if that means whether CF people are getting the same kind of problems as other people. You know, we think that we're at high risk as a community because of the chronic lung disease, which may or may not actually, at the end of the day, be true. There's some supposition that maybe some parts of CF actually help. I think what helps is our infection control practices, actually, more than any biological issues that have to do with cystic fibrosis. But of all the cases that have been out there, all those people are either still having symptoms and stable or have recovered. So that's the good news. At least we have no reports of fatalities in the CF community at this point that I know of. And I understand completely what you're saying about our infection control practices that we've been practicing for years and years, being a benefit to us. I have heard about people who theorize whether people with CF have special protections because of the chronic state of inflammation that individuals with CF are living with, especially in their lungs, and whether this has any connection with the cytokine storm that has been killing many people. So 2 parts of that question. Do you think there's relevance to that? But also, if we could just explain in layperson's terms the whole cytokine storm. Yeah, so let me take the last part first. The so-called cytokine storm is something that people have noticed before COVID occurred in people that were critically ill, who developed multiple organ failure, including lung failure, which they call acute respiratory distress syndrome, particular kind of lung failure. And in many of those situations, part of the problem seems to be that the body's response switch has been turned on and ramped up to 10, and nothing has been able to dampen that. And so the cytokines are these chemicals that are produced during inflammation. We can measure them in blood or other body fluids or tissues. And those that fight off infection are way up in these situations and then don't go down. So that's actually led to the development of some drugs which target that. And some chronic autoimmune diseases have chronically elevated levels of these cytokines, and some of those products are being used to treat things like, for example, rheumatoid arthritis. So
um, some of these drugs have now been applied to people with COVID who are in the ICU, and clinical trials are occurring with that now, but we don't know for sure whether they'll help out. I think it's likely that in some cases they will, because those cytokine levels are so high, and something that dampens that should theoretically be of some use, but we don't really know yet. Now, whether CF is protective in some way and not just a vulnerability is still an open question. I think one of the things that is key is whether the levels of the receptor for the virus, which you call ACE2, this molecule on lung cells and elsewhere in the body, is that changed in any way in CF? And the question is relevant because we do know that CF, the CFTR protein, affects the function of many of these levels of receptors or other molecules present on these cells. So it's an open question. To my knowledge, no one has gotten to study it yet. Things are a little bit too frantic right now, but I think eventually people will be able to look at things like the expression of the ACE2 receptor in CF and see whether or not it's increased, which might make you more vulnerable, or maybe even down, and which might make you less vulnerable. But that is all to be sorted out at this point. We just don't know enough.
What are the current treatments for COVID-19? Have there been any new drugs that have been tried? Are they working? If so, are they working? Have treatments changed since the outbreak of this virus based on what we've learned?
Treatments have changed in terms of supportive care to some degree. I think people are particularly intensivists, have realized that some of the techniques that they have used, such as early intubation and putting on a ventilator, may not help in all cases. And so they've been becoming more selective about that. And there are various non-invasive ways to support getting oxygen in. Besides just giving low flow oxygen, you can give high flow oxygen. And you can also give oxygen with some pressure without putting an endotracheal tube down somebody's throat. So all those options are now being explored very actively and may be quite helpful. So those are really non-drug things that have to do with preserving lung function. In terms of drugs for the disease, COVID, I think we do have some very promising things going on already. These are mostly focused on the very sickest people who are in the hospital, in the ICUs. And one of those is this antiviral drug, remdesivir, which was developed for SARS and never used. Which is showing some very good promise at this point based on very early uncontrolled studies. So that needs to be validated by properly controlled studies, and those are underway. The other thing that I think is very helpful is the fact that people who have recovered and are presumed to be immune can have blood taken, the plasma purified, and then that plasma can be given to very sick people in hopes that the antibodies that are present in those recovered people will then be transferred to the sick people. And again, very early trials with that are also looking very good at this point. So we have two things that, to my eye, are looking very promising, but not yet quite validated. And then we move to really the big one, which is hydroxychloroquine. That's been, the FDA has released that under what they call an emergency use authorization for people in the hospital. So this is not to be taken prophylactically, but when somebody's already sick and sick enough to be admitted to the hospital. There have now been 4 or 5 trials, several in France, one in China, one in the United States, and the results are pretty much all over the map. So we still need better data on that. There may be a situation where the drug is useful. Certainly in the test tube, it does have some properties that look very promising. And it is cheap, it is available, so we really need to get that answer. But at this point, we also have to caution that this drug is not without side effects, including sudden death from heart arrhythmia. So these things all need to be put into balance. And the way you get the final answer is what's called a placebo-controlled trial, where some patients get a placebo and some get the drug. And it's double-blinded, so you don't know who's getting what, and then you look at that result. And that, at least one of those trials has been now started by the NIH, and several others, I'm sure, are also underway here and around the world. The World Health Organization has a very large study underway across several countries. So I hope that within a month or so, we'll have much better information about hydroxychloroquine. I think there are two downsides that people with CF need to keep in mind. Number one is the side effect issue. We don't know all the interactions of this drug with others. We don't know how its side effect profile in CF resembles or may be different from other people. So that side effect profile is a problem. And the second thing to keep in mind is the fact that this is a drug which people with other diseases need, not just malaria, but things like rheumatoid arthritis and lupus. And some of those people have reported that they can't get hold of the drug because it's being used in this epidemic. So those are two things to keep in mind in terms of just having, trying to get a supply and have it in your shelf, just in case you start to develop any symptoms. I think that's going too far at this point. We really need to see what these other studies show. And if the patient does get sick, if you do have a problem, you will have access to it under the emergency use authorization.
Got it. So continuing in the same thread, somebody asked, how can the BCG vaccine for TB potentially help with COVID-19? And why is BCG not routine in the US as it is in other countries?
So the second part first, BCG is a vaccine that was developed over a century ago. And it's been used since 1921. It's for TB. It also works against some other forms of mycobacterial infection. It's basically a weakened form of TB. So it's a live attenuated vaccine. And the reason it's not given in the States is that the risk is very low in the States. And the question of side effects and also muddying the waters in terms of later testing are issues for low incidence countries like the United States. In other countries where TB is much more prevalent, it's given to newborns. And then its main effect is really not to protect so much against regular lung TB, but it protects babies against disseminated TB, TB meningitis, killer type situations for infants. That's the main reason it's given in most of the world. Now, what we've learned over the years is that BCG has an effect on the immune system to stimulate what we call the innate immune system to become better at encountering other germs for the first time. So it has an off-target effect of revving up the immune system. And that's led to the idea that, hey, maybe we should be giving BCG prophylactically for this epidemic. And there actually are now some trials that are occurring. Again, these are mostly outside the US. I think there might be one US trial planned to try BCG as a way to protect against COVID-19. It's a theoretical idea at this point rather than proven.
That is fascinating. And so
Very fascinating, yeah.
Were put in place, they do the trial, they decide it's worth it. Will people later on be showing like false positives, so to speak, for TB?
Well, it does have an effect on the TB skin test. And that's one of the reasons that in the United States, where the incidence is so low, the public health authorities, the CDC, and other authorities have decided not to implement that for general use. If you go south of the border in Mexico, it is being given to infants routinely. So people coming across, for example, from Mexico into the US will have reactivity on the TB skin test, and so it makes that whole surveillance issue a little bit more difficult.
Amazing. Maybe a loaded question. Who decides when quarantining is over? Do you know when the first wave of release from home quarantine will be, and who will get to resume daily life first?
Well, this is a bit of a political issue in our country right now because the president has said, I have the authority to tell you that. But in fact, under the Constitution, it's reserved to the states. And most states actually put most of that power in the hands of local health authorities, the county health or city health departments. So in most cases, the public announcements come through more locally. They'll come through your governor, or they'll come through your mayor or your county health department. And they usually have a date when it's, they'll say, this is our target date to reassess. And as you know, they've been reassessed and kind of the clock gets getting pushed back because we are realizing this is a longer term process that is going to be necessary. So my answer is really it's going to be a decision that is mainly at the state and local level. There'll be some coordination. We may get guidelines from the federal administration, but the actual power to enforce is going to be through the states and the local governments.
So what needs to happen before it's safe for the CF community, as opposed to the general population, to go out in public again? Will we need to wait for a vaccine before we can live our daily lives again?
That's a really complex question. It's a really good one. I think it's going to depend on the fine print of each particular locale in terms of what the lifting means, what are the actual details, who is going to be allowed to be off of that stay-at-home order. And I don't differentiate between CF and non-CF in those terms. I think they're going to make a decision based on general health. And if the risk is low enough to allow the general population, for example, to go back to restaurants, that will apply to CF as well. Keeping in mind that, you know, the infection control measures which CF people have been used to are standing us in very good stead. And of course, they're extended now from the healthcare setting, you know, when you have that in the clinic or in the hospital, or the social setting when there's other folks with CF involved. Now it's all of society that's kind of in this bubble, right? So it's going to be an individual decision as to what the risk versus non-risk is of doing something once we have some kind of lifting of a particular social distancing measure. There are going to be different forms of this. So they may be applied just to people in certain essential services. They then may get expanded to people at lowest risk, maybe a certain age group. A lot of this depends on the testing situation. If we actually have the data from testing to know who's not exposed and therefore vulnerable versus who has actually been exposed and developed and at least antibodies, which we hope are a sign of immunity, then they'll be able to make much firmer decisions about how broadly to do this. In terms of the science, I'm not an epidemiologist, but I do try to read these papers, and they've been very much on the conservative side that until we really have the solid information from widespread testing, we're not going to have great guidance. And so the danger level would be higher than otherwise. So we have to be very cautious about the lifting of the various quarantines that are being used right now. It's not a good answer, but it's maybe what we all have to live with for quite a while.
Absolutely, absolutely. Do you anticipate another spike in the curve after people are released from home quarantine? And you know, part of that, hearing these reports that they're seeing people who had been cleared or recovered who are now testing positive again for COVID-19 in, I think, China?
Yeah, that's right. So some recent information indicates that some portion of people who have recovered clinically, who are now okay, are still harboring the virus on the test. And this is somewhat disturbing because presumably one of the reasons that they were discharged was that they had a negative test before discharge. And now they're showing up again positive. So that raises the issue, are they getting reinfected? And most people say the answer is probably not. They're probably reactivating. The virus has stayed viable somewhere in their body and then is able to make a minor comeback and turn the test positive back again. We don't yet know what that means in terms of infectivity, but we just assume that a positive test means that you definitely could spread the virus. So that just gets back again to the fact of masking, hand washing, social distancing, all the things that are working to try and stop the transmission. The only way we really know that we can stop the transmission is to keep bodies apart. and unfortunately, that's what this is all about.
Somebody asked, does a ventilator interfere with immune system response?
Generally, ventilators are, if anything, they increase inflammation because you're disturbing the normal anatomy by using forcing air in, and also especially the tube. So bacteria and other things can grow on that tube that goes in from your throat into your windpipe. Those things all stimulate the inflammation. So I don't think there's any evidence that ventilation per se suppresses or reduces either immune system or inflammation, and there is evidence that it does increase inflammation in some cases.
Next question, which I didn't put this in there as a plant, but I know you can speak to this, is situation report on rationing scarce medical equipment in the US. Do we need to worry that with CF will be discriminated against for treatment of CF exacerbations or COVID-19 treatment due to having underlying health conditions or low lung function?
Yeah, so there are several aspects to that. The most important is getting back again to the idea of flattening the curve. One of the reasons that whole concept has really convinced everybody of its importance is it relates to the resources of the healthcare system, in particular ICU beds, ICU personnel, ventilators, those kinds of things that are necessary for the very sickest patients. So that has led, and this actually predated COVID in terms of discussions. In a pandemic, how do you make decisions about who gets care and who doesn't? Some of the guidelines that have been put out by certain state Medicare agencies have reflected obsolete data about cystic fibrosis. And as you know, Siri, we've already written a letter about this, which is awaiting review, in which we argue that these obsolete data need to be brought up to date. And what those show is that people with CF, even if they're on a transplant list, may still deserve that kind of care because of better survival statistics. So luckily, most cases, including New York City, seem to have been able to flatten the curve enough to not overwhelm their capabilities, although they're right on the edge and have been for the past week or two. But as of now, it looks like we're okay. There are certainly places, it did occur in Italy and Spain, where they were overwhelmed for a while. But at this point, it looks like there'll be enough to get around. So hopefully those decisions don't have to be made. But if they do, we now have very good input from a number of different sources to hospitals on guidelines of how to deal with that. And those involve things like having a triage officer who's not the same as the treating physician. So you get an independent voice. Most hospitals have ethics committees, and the criteria that are used are now much more individualized, so that we look at things like how long you've lived already, not just how old you are, but how long you've lived. So a younger person may anticipate a longer life ahead. That's a factor to consider. And also what our best predictors are for individual survival out of the ICU, discharge, and then life beyond that. It's still very messy and very difficult. And there are situations where terrible decisions may need to be made, but at least the methods of evaluation and recommendation, I think, have greatly improved from what they were in the past. And the CF Foundation, we at CFRI, and many others in the rare disease community have made it very clear to public health people and the government and governmental agencies that we want to protect our community from any kind of discrimination based on a diagnosis.
I think it was shocking for many of us to actually realize that there are these state emergency plans that specifically name cystic fibrosis as an exclusionary or deprioritization criteria based on lung function. So the good news is that now we do know, so we can hopefully get these things corrected. And obviously, as you said, I mean, hopefully these will never come into play anyway, that it will remain a theoretical discussion and not put into practice. So
I hope so.
Let's see. I learned, this is a long question. I learned that they are rationing all inhaled medications in preparation for a surge of treatment for COVID-19, including Albuterol, Advair, Flovent, etc. With Albuterol and many of these medications being standard daily treatments for CF, we've been told there'll be no early releases on these medications, and that those of us on inhaled medications for CF may be switched to nebulized Albuterol in the meantime. Is this a shortage issue or a rationing issue? Either way, how long will this be an issue for us? I don't expect you to have the answer about the length of that. But other,
The best of my knowledge, it's not as short as issue. There's enough of the drugs, but it is a rationing issue in the sense that the supply is being diverted to take care of COVID patients, especially things like albuterol. Some of the medications used in the ICU for sedation, things like that. Most of those are not relevant to CF, but albuterol and other bronchodilators might be. I haven't heard of the actual recommendation that people are getting told to switch from an inhaler to a nebulizer. The only caution there is that nebulizers will aerosolize virus more than an inhaler. So if there's any exposure risk or history, that in my mind would be a no-no. You don't want to do that. So you can push back on that basis perhaps. But yes, there may be problems and shortages, for example, like we talked about with hydroxychloroquine for people with lupus. They may not be able to get a hold of it because it's being used for this epidemic, and in some cases, maybe not appropriately. So we do have to be pretty vigilant about this situation. But I think the supply is not the issue so much as where those supplies are going. It may affect the refill issue that I think was alluded to in the questioner. So you may not be able to get a 3-month supply. They may say, oh, okay, we can give you a 2-week. We'll give you 1 inhaler, we're not going to give you 3 or something like that.
right. And I had heard that part of that problem is because of what you mentioned, that with the nebulizer, it could spread the virus so much that in hospitals, that nebulizer is not an issue. So they're channeling more to the hospitals to help.
Exactly. In the hospital, just going from an inhaler with a mask to using a nebulizer might involve a whole set of protective equipment. And that's probably the thing in shorter supply now, is some of these PPE equipments, the masks, the shields, the gowns, the whole bit, the gloves. Those things are all in short supply. So yes, that's a spillover effect. So one should be careful about that, especially in the hospital.
What about those with CF who are on the transplant list? Are they still providing transplant surgeries as they normally would, or has anyone lost a chance for a double lung transplant due to this virus and the rationing of ventilators, etc.?
Yeah, I'm not a transplant person, so I can't answer that from any direct experience. I would hope not. I think, transplant itself is not an elective procedure. You get the transplant when a match shows up, and that's a rare occasion, right? And we all know about that. So I'm assuming that anyone who's listed is still going to get that transplant if a donor becomes available. It may be complicated by the need to test the recipient and the donor, make sure everything's okay in that regard. But short of that, it should be okay. There may be issues in terms of the availability of that ICU bed. So yes, I can't answer for any particular transplant center what the situation is in their ICU right now. They may not be able to do the transplant because of the lack of the bed. So, or the providers, it takes that huge team to take care of each transplant recipient. So I think it could be a problem. The best advice I might offer is just to make sure that anyone who's listed or is in the referral process, keep in close touch with your CF center or your transplant center and get the best information you can about their state of readiness to do a transplant if a donor became available. Now, for people who've already gotten it, those visits are, whether they're telehealth or personal visits, are going to depend again on an individual assessment of the status of that recipient and what's going on in that community. So again, it's all about communication and really keeping track of where things are at for your particular case.
There are so many things to think about with this and so many areas it impacts. Incredible. Well, how reliable do you feel the information is coming from China?
Well, I don't have any insight beyond anything anyone else is reading in the media. We do know that the Chinese suppressed information in December and early January. That's for sure. That's out there. That's been validated by enough people inside China so that we know that's a fact. What's less clear is what's happened once they put the lockdown in place and did things that would be virtually impossible in this country. They basically put something like 160 million people in their homes for 8 weeks or something like that. But you know, what they've done since then in terms of lifting restrictions, how many cases they've had, what they're reporting, there's been skepticism about that. I know I've read about that. One of the big beefs that President Trump has with the World Health Organization is that he feels the WHO has been too accepting of China's information. There's also an element of, you know, finger pointing and blame that you're responsible for this whole thing. There's politics and there's biology. Those are two different situations. So I don't know how reliable the figures are from China. All we know is that what they've said is that they have contained this disease. They've closed their borders to people coming in now because all their new hotspots are from people coming into the country. So that would seem to indicate that they really have gotten a good situation, but there are stories that there's a lot more going on there than has been provided to the outside world. I think we have to leave it at that.
So someone asks, what exactly has the World Health Organization done to have funding cut by the US and be reviewed for mismanagement? Do you recommend this organization as a credible source of information?
My understanding is that the funding has been suspended, which means it might be reinstated. And with this administration, you often get one decision one day and the opposite decision the next day. So I wouldn't be surprised if that funding is resumed at some point. All we know is what President Trump has said, that he thinks that they have not been sufficiently tough on China and that they were remiss in alerting the rest of the world. It is true that the WHO did not formally declare a pandemic until late February, and I think that some people would have liked that to occur earlier. But I mean, I and many other people were tracking their statements daily, and they were all appropriate in terms of the actual information they had at the time. In addition, their scientific base is very solid, and I think their recommendations continue to be very solid. So I would separate the political issues involved here from the strictly medical and scientific issues. So I think people can continue to rely on the scientific information that they are presenting. And we can leave the politics to play out on the political stage.
Thank you. With new studies showing that this virus can aerosolize up to 16 feet, I don't know if people saw the New York Times with their 3D model after a person sneezed and coughed. How safe are we walking outside and passing people 6 feet away from us?
Yeah, it's again, it's not an all or nothing thing. And I think one thing that people should keep in mind is the likelihood that whether or not one can actually catch this from an aerosol will depend on the concentration and viability of the particles. That means the closer you are to that person and the longer you're in contact with them, the higher the risk is. If you're out walking in your community and somebody else is walking down the street and you pass 6 feet from each other, I think the risk of anything happening there is minuscule. It may not be zero, it might just be barely detectable. But the likelihood of getting sick from that is very, very, very low. So in a closed environment, which is different, if you're in a room and somebody is positive, that's a bit of a different situation. So I think you have to pay some attention to the type of environment that you're talking about in terms of this distancing. It is true, the 6 foot rule is the world doesn't stop, there's no curtain there at 6 feet. The air is a continuum. So something that was there just before 6 feet could be traveling a little bit beyond 6 feet. So you just have to use your common sense. In a healthcare setting, it's interesting, people are put at high risk if they're within that radius and exposed for longer than 10 minutes. Again, that's an arbitrary decision, but this gives you a flavor for the fact that we have to make some judgment calls about this and how vigilant to be. And generally, the further apart you are, the better, and the less time you're in that proximity, the better. And then within that, use your common sense. Are the people wearing masks? That cuts down the chances tremendously. Make sure there's no direct contact, no contact through fomites, objects, and then the risk is very low. So I think the 6-foot rule is very reasonable in the general context of how you're dealing with others socially.
And this just makes me so appreciate those healthcare providers who are exposed for hours and hours and hours.
I saw one quote that really stuck in my mind from somebody who was working in an ICU and said, "I spend half my day standing next to the reactor," because he's actually intubating people. He's within inches, and knowing he's aerosolizing because of the way that the instruments you have to use and things you have to do. And that's heroism to do that.
Yeah, amazing. So a question about masks. Can you wear the same mask twice if it is to protect the world from you, meaning to hold secretions in? I use a different disposable mask at every stop I make for groceries, but I'm running low. Now that people are using scarves, bandanas, or homemade masks, how would I clean those? And should I wear a different scarf or bandana with each stop once I run out of the disposable masks?
Yeah, that's a good question. I think in general, if you're making masks or getting the cloth masks, or lots of people are into making masks. We've made some here at our house. You can have several for each person, and then you can just cycle them. So you can wash the mask after you've used it, and use the unused mask, and just cycle back and forth. Even if you have to go out every day, you're still able to do that. And most folks are not going out every day. You're going out to shop once a week, maybe, right? Or just taking a stroll is fine. So there have been studies now that have shown viral particles can actually migrate from the inside of the mask to the outer surface. So it is important, I think, to clean them, to wash them. And again, I wouldn't go crazy about it. I think just doing a regular hot cycle wash and dry is going to be sufficient to make it safe to reuse them. If you've got reusable masks, it's a precious resource. So we should think about having those for healthcare workers at this point until the capacity is up, and every store you go into has a huge shelf of this stuff,
Mm-hmm.
Yeah.
Well, that was the last question on this list, but I do like that we ended on masks because I do want it to become like the norm as opposed to the exception, with the tide turning of a few people with masks, most people not. I think.
Yeah, the world is changing. I heard Dr. Fauci say we should never handshake again, ever. And, a couple months ago, that would have been an incredibly radical, way out there, bizarre statement. And today, you take it seriously. Maybe we need to think about the place of the handshake in society. And, should we be bowing? Should we be elbow bumping? There are various other ways to get that social hit from each other. Yeah.
And I have to say, we have to get that clip of him saying it, because 2 months before this all happened, the CF Adult Advisory Committee had launched a whole no handshaking campaign, and who knew how relevant that would be. And yes, may it last. The
CF community, we are experts in this whole thing at this point, right? So much of this is familiar, and so much of this is something that we've already changed our thinking about. So it's not the kind of psychological problem it is for many people now. And I think 6 months from now, the world will probably look very different than it does now, just in terms of how people behave in social settings.
Well, again, I thank you for so generously sharing your time and expertise. Do you have any last thing you would want to share with people before we sign off?
I think it's the only thing I'd say at this point. This is our 4th week, I think, of doing this. This situation is going to go on for a very long time. The coming out of it is going to be a very gradual process. It's going to extend, I think, well into the summer, maybe into the fall. And so I think the most important thing now is for people to have patience and have determination that, yes, we'll get through this. We will get the treatments and we will get the vaccines, but it's not going to happen in a very short framework, and we have to be patient.
Well, thank you very, very much. And I'm sure there were more questions coming your way.
Probably. Probably will be, yeah.
All right, thank you.
Okay, take care.
Bye-bye.